Okay, I'm going to talk about a randomized controlled trial of 3.0 mg of liraglutide in weight management. I'm Deandra Villamar and I'm going to start. First, we have about the case that obesity is a chronic disease with a serious health consequence, but weight loss is difficult to maintain through lifestyle intervention alone. Liraglutide, a glucagon-like peptide-1 analog, has been shown to have potential benefit for weight management at a once daily dose of 3.0 mg injected subcutaneously. Now we're going to see a video about the case.
The prevalence of obesity is increasing around the world, and effective interventions to combat this trend are critically needed. Liraglutide is a glucagon-like peptide-1 analog approved for the treatment of type 2 diabetes that has shown potential to decrease appetite and cause weight loss. In a new trial, investigators compared liraglutide injected subcutaneously once daily with placebo to assess weight management in overweight or obese adults who did not have diabetes at the start of the study. 3,700 participants with a mean weight of 106 kilograms were randomly assigned in a 2-to-1 ratio to liraglutide or to placebo. At 56 weeks, those in the liraglutide arm had lost an average of 8 kilograms, as compared with a mean weight loss of 2.8 kilograms in the placebo group. With liraglutide, 33% of participants lost more than 10% of their initial body weight, while only 11% of the placebo group lost that much. The most frequently reported adverse events were mild or moderate nausea and diarrhea.
Okay, application in medicine. We conduct a 56-week double-blind trial involving 3,731 patients who did not have type 2 diabetes and who had a body mass index, BMI, the weight in kilograms divided by the square of the height in meters, of at least 30 or a BMI of at least 27 if they had treated or untreated dyslipidemia or hypertension. We randomly assign patients in a 2-1 ratio to receive once daily subcutaneous injections of liraglutide at a dose of 3.0 mg, 2,487 patients, or placebo, 1,244 patients. Both groups received counseling of lifestyle modification. The co-primary endpoints were the change in body weight and the proportion of patients losing at least 5% and a more than 10% of their initial body weight. We're going to see another video.
In that amount of flesh, that sounds kind of, weird, but if you were to convert that into energy, you would get about 3,500 calories, which is quite a lot of energy.
That's me talking with Dr. Carson Chow, an MIT-trained physicist and mathematician, and he's explaining to me why we should care how much energy fat has.
In order for you to live and function, you need to burn energy to keep your heart beating, all your organs going, and also to move around.
But energy doesn't come for free, so if you're not consuming enough calories, you're going to burn that energy with your own fat. And so a lot of diet books like to teach people this rule, but the problem is it's wrong. And here's why.
So let's say I eat 500 calories less a day, so after 1 week it would be 3,500 calories and I would lose a pound, right? Because I'd have to burn it.
Yeah, and if I stayed on this diet for a year, I would burn through 52 pounds.
Be great. If you keep taking this thing, well, after 2 years I'd lose 104, and after 10 years I'd lose 500 pounds, So obviously at some point.
Now we have pros and cons.
Obesity is a condition that is associated with having an excess of body fat. Obesity is classified as having a body mass index of 30 or greater. 3 decades ago, the obesity rate for adults was 15%. Today, the rate has more.
Pros, there was a greater reduction in glycated hemoglobin, fasting glucose, and fasting insulin levels in the liraglutide group than in the placebo group. Liraglutide was also associated with a lowering of plasma glucose levels and higher insulin and C-peptide levels relative to placebo during an oral glucose tolerance test. The effects of liraglutide on glycated hemoglobin, fasting glucose, and glucose levels during the oral glucose tolerance test were greater in patients with prediabetes than in those without. Measures of insulin resistance and beta cell function also show improvement with liraglutide as compared with placebo. Now we have cons. Gallbladder-related events were more common in the liraglutide group than in the placebo group, occurring in 61 of 2,481 patients, 2.5%. 3.1 events per 100 patient years of exposure versus 12 of 1,242 patients, 1%. 1.4 events per 100 patient years of exposure, including more cases of cholelithiasis and cholecystitis in the liraglutide group. Most patients who reported cholelithiasis or cholecystitis underwent an elective cholecystectomy. 40 of 51 patients, 68%, in the liraglutide group, and 6 of 8 patients, 75%, in the placebo group. And most recovered and continued their assigned course of treatment or had treatment reintroduced after surgery. 43 of 51 patients, 84%, in the liraglutide group, and 6 of 8 patients, 75%, in the placebo group. The weight loss among patients with gallbladder-related adverse event was greater than the mean weight loss in the total population. Now we have issue applied in Ecuador. In Ecuador, the clinical relevance of increased resting pool with liraglutide is unknown, but is probably related to the drug class. The presence of glucagon-like peptide-1 receptor in the sinoatrial node suggests a direct chronotropic effect. No increase in the number of serious cardiovascular events was observed in the liraglutide group, and beneficial effects of liraglutide were seen with respect to blood pressure and other cardiometabolic variables.
Rafael Correa announced this past weekend that the government is considering imposing a tax on fast food. Denmark was the first country in the world to impose a similar tax in 2011 following World Health Organization recommendations.
In our country, we know that about 30% of children and teenagers have nutritional problems related to being overweight and obese. This makes these children more prone to the risk of developing chronic, non-transmittable diseases in the very near future, like diabetes, hypertension, and maybe some blood disorders. So what?
Now we have conclusion. In conclusion, 3.0 mg of once daily subcutaneous liraglutide as an adjunct to diet and exercise was associated with clinically meaningful weight loss in overweight or obese patients, with concurrent reductions in glycemic variables and multiple cardiometabolic risk factors, as well as improvement in health-related quality of life.
My name is Lotte Bjerg Knudsen, and I work for the pharmaceutical company Novo Nordisk, which is located in Copenhagen, Denmark. The purpose of the study that's presented here in this article was to study the mechanism of action for liraglutide in weight loss. Liraglutide is an analog of human GLP-1 that has been engineered to have a long half-life so that it is suitable for once daily injection to patients in a simple pen device. And liraglutide has already been approved for the treatment of type 2 diabetes, but is now in clinical development for the treatment of obesity.
Okay, thank you.